Hi everybody and welcome to our webinar today. It's a public health update of the response to COVID-19 in residential aged care facilities for the Central Coast. My name is Jenny Pearson. Before we go any further, I'd like to acknowledge the traditional custodians of the land that we're meeting on today and pay respect to elders past, present and emerging. I'm coming to you from Enewan land in the Northern Tablelands. We have some great presenters for you today. We have Sally Freeman and Gina Stewart, who are CNC in the communicable diseases stream for the Central Coast LHD. Cara Pollard, who's an operational lead for the COVID-19 Public Health Unit. And we also have Lynn Beckerstaff, who is a District Director of Nursing. So I'm just going to hand over to Cara. Probably actually said what she was going to say, and we'll go from there. Just before I do go, don't forget that if you have any questions, please type them into the question box. We have Jacqueline Hewitt here from the PHN who's going to facilitate the questions today. And at the end of the webinar, an evaluation will pop up. And if you could please fill it in, it only takes about 30 seconds. And you all will get a certificate of attendance as well, which will arrive in your email box in a couple of hours. All right, thanks, Cara.
Thanks, Jenny, and thank you to the PHN for organising that. We really appreciate it. But before we start off today, as Jenny said, we are going to hand over some time to the Central Coast District Director of Nursing, Lynn Beckerstaff, to talk to you for a little bit, and then we'll go back to our presentation. So thank you so much, Lynn.
Thank you, Cara, and good afternoon, everyone. I know there's many of you on the line or on the webinar today that I actually had the pleasure of working with over Christmas. But really, I wanted the opportunity today to actually come together with all of you to pass on our acknowledgement, our congratulations on how the residential aged care facilities on the Central Coast have actually managed this Omicron wave. As I said, I got to talk to many of you, particularly over that Christmas New Year period. We cannot thank you and your team enough for your calmness, your preparedness, but how you responded to the situation. We also, the Chief Executive and the executive team and our colleagues, your colleagues here at the district, recognise that your preparedness, your systems and your processes have actually kept your residents safe, but you've made a dramatic impact on how we as the Coast and the Central Coast Local Health District did respond to this latest wave. We also acknowledge that it hasn't been easy, and we congratulate you, but most importantly, I personally want to recognise the personal commitment, particularly to all of you that have been managing the facilities. I know it has been a very trying time. So just a quick message acknowledging, and I think I also need to say to you that your response, but also gives us greater confidence in the whole of system approach that you have invested many hours of resources, knowledge and expertise during the pandemic. So once again, congratulations and thank you. Back to you, Cara.
Thanks, Lynn. We appreciate your time today. Thank you. I think we're going to have the slides come up in a second. Excellent. Thank you. Oh, next slide, thanks. So today we're just going to be talking to you for not too long, but trying to explain a little bit more about the outbreak reporting and how to do that for the public health unit as part of your response in residential aged care facility outbreaks. So we're starting off by how to report an outbreak. Then Sally's going to talk to us about undertaking a risk assessment for that outbreak and how to determine that and use the risk matrices. And Gina's going to finish the presentation talking about a line list and the importance of those and how they can assist you in managing your outbreaks as well. So on this slide here, and these details will go out for you, but we're just reminding people that we do actually have a dedicated email address and phone line to report or just get in contact with us. And those details are just on the bottom of the screen there. The main public health unit number for Central Coast, and then option 1 and then 3. We've tried to make that a bit simpler, but you will get through to someone to talk to Monday to Friday, and we do have some on-call staff on weekends as well. If you need any assistance, please contact us. Next slide. Okay, so this is the lovely definition of reporting an outbreak that was, relevant 10 minutes ago. And as we know does happen in COVID world, things change quickly. So at the moment, the definition you may be familiar with and that we're familiar with in Public Health Unit in New South Wales is that a COVID outbreak is one positive resident who's been diagnosed and confirmed with a PCR test, or 2 or more staff that have that are COVID positive within a 72-hour period, and also work during their infectious period. As you may have seen, some changes came along to that this morning. And whilst New South Wales hasn't actually confirmed it yet, the CDNA guidelines that came out today actually confirm that the newer definition of an outbreak will actually be 2 positive residents within a 5-day period. So please just watch this space and make sure you're up to date with that. As soon as the information is confirmed by New South Wales Health, we can forward it through as well to people that attended this through the PHN as well, just to confirm that. But that's looking like what it will be: 2 positive residents within a 5-day period, or 5 or more staff positive within a 7-day period. So that is, as I said, a changing situation at the moment. The other update that you may not be aware of is with exposures. So at the moment, exposure is just 1 positive staff member or visitor that's been exposed, and it doesn't have to then go to an outbreak status. So that's still the same, that 1 positive staff or 1 positive resident makes it an exposure. And the key there is that they're actually moving to more of a self-management model for exposures. They don't necessarily have to be reported to the public health unit. However, we're still more than happy for you to do that, and we're more than happy to assist you in understanding whether what you have is an exposure or an outbreak. But if you wanted to manage the exposures yourself, that is an option that they have made available now, that they don't necessarily have to be reported to the public health unit. Just something to remember too when we're looking at these definitions, that infectious period is generally considered to be 48 hours prior to symptom onset or test date if someone's asymptomatic. The local health district is the operational lead that confirms the presence of an outbreak and can provide further advice. And just a reminder too that outbreak status does not necessarily mean lockdown. So sometimes we get facilities that get confused, that thinks that the outbreak definition means lockdown definition. It's simply a status, and we can work with you, and you'll see from the risk matrix that Sally will talk about soon that it doesn't necessarily mean your facility needs to be in full lockdown when you're in outbreak status. Okay, next slide. Okay, so we understand, like Lynn said, that this is actually quite a trying time, and you guys have a lot of people that you have to report to, and a lot of paperwork and forms and things like that that you need to fill out, and we understand that that can be really cumbersome. So we're trying to simplify it for you, and we've actually got an outbreak reporting form now that you can simply complete. And it's an online form. It uses a survey system that we use here called RACF. And it basically collects all the information that we need to help you with your outbreak or exposure. And what will happen is when you complete that survey, so normally we will send you a link to complete that survey, or there will actually be a landing page in the future from the Central Coast internet page. Once you complete that survey online, you will then get an automatic email with all the links and any resources that you need to assist in that outbreak reporting. And the good thing is you can do this reporting anytime. So, you don't have to do it during business hours. You can sit down in the afternoon when you've got some more quiet time and do this reporting, or on weekends it's available there. Can I have the next slide, please? So the kind of questions we're asking in the outbreak survey is really basic. Obviously, just contact details. We need to know who is the best person to contact when an outbreak occurs. The name of the person, contact phone numbers and email address, so we can make sure that we can get in contact you when needed. The current positive cases that you have, so the details of the dates when they tested positive, which really helps us when we're counting for times and periods in the outbreak. Exposure of these cases to other residents. And then something that's really helpful for us, because we're dealing with a lot of different facilities here, is the layout of your facility, the names of your wings in your facility, and your facility numbers. Just really getting an understanding of that does really assist us when we're talking to you about wings that might be able to come in and out of isolation during an outbreak, or cohorting of staff and patients. If we've got that survey in front of us, which shows us your wing names and the numbers and things like that, is helpful. So thank you to everyone that's been doing that. And then the information that we collect from you is a line list, and Gina's going to talk about that later. So I guess just the summary from my section is that we appreciate you guys do have to do a lot of reporting. We're trying to make it simpler for you with a survey link that you can fill out now when you're reporting. But if you have any issues with it, please don't hesitate to contact us and we'll assist you in that reporting. So we're going to go to Sally now, and we go to the next slide. Sally's going to talk to us about the risk matrices and how to actually rate the risk of any outbreaks that you do have or exposures. Thanks, Sally.
Okay, so hopefully everyone can hear me. So when we're looking at things in terms of the exposure, we're looking at the risks, so low, medium and high risk scenarios. And a lot of these risks, when we talk about this, is you're looking at the amount of PPE that people are wearing and the activities that are being undertaken. So something that's a low risk scenario will be that minimal or transient interaction, moving through a dining room, collecting rubbish, that kind of thing. That is that small, short time frames, transient movement between areas. When we're talking about medium risk scenarios, we're talking about close contact for up to 4 hours. And we're talking about cumulative exposure in these situations. Sometimes you may have someone who has not been picked up as a positive case for a number of days. Because this time has caused a delay, you've then got potentially up to 48 hours of potential exposure. So you're looking at that 48-hour period, not they tested positive today, what have they been doing today? So if someone's been working, administering medication, transfer assistance, shared recreational activities for short periods, that may come into that medium risk scenario. But when we're talking about things like high risk scenarios, it's close contact, more than 4 hours, longer periods of time, or things that involve risk, such as assisting residents who have behavioural challenges, aggressive, yelling, close personal care activities. When we think about the kind of activities we do to support your residents, when you're looking at doing a shower, they may need shower and toileting assistance on multiple occasions through the day. They may need feeding assistance. They may need personal care attendance. So that might cumulatively come up over that 48-hour period as quite a prolonged close contact. And they're also looking at things like aerosol generating procedures. So they're things that force air out. So things like CPAP, so anyone who has maybe a CPAP machine at night, any of your residents who are on home oxygen, nebulizers, any of those activities, that's going to increase that risk. So we're looking at there's a greater risk there. So what does that look like? And what's the cumulative exposure been in that time? Next slide. So you've got the risk matrices that assist you with that decision-making process. So you've got one for staff and one for residents, and you've got some recommendations of actions to take depending on the risk. So when we look at a matrice, we look at what has been used and what the contact in terms of PPE and what the contact type is. And it's a little bit art, a little bit science. But what you're looking at is you need to really break this down. It needs to be individualised. You can't sort of just blanketly go, oh, well, someone was walking around, because some of the behaviours and some of the interactions may have been different. And these are the things that you need to start considering when you're looking at stepping down PPE after an outbreak. How much risk is there with stepping down your mask, with removing eye protection, all those kind of things? Where does your risk sit? And how is that appropriate for the kind of care that that role's undertaking? So it may be appropriate to maintain a higher level of PPE in some roles, step it down in others. And this is where you can use the risk matrix to not only assess potential for risk, but also the exposure that has occurred. So you look down the side and you look at whether the person is a contact or a case. So if the staff, the contact in this consideration, the case may also be a staff member. Okay, it's just in terms of assessing the risk. You can see there when they have an N95 or a P2 mask and an eye protection, we stay in that low risk section. What you need to consider there though is, if the case is a staff member and the contact's a staff member, did something occur such as a meal break, interactions without PPE? And what does that look like in that cumulative risk period? Because we would need to assess that. As you can see, once we get to the no PPE, the risk actually goes up when you turn to the right-hand side. So it's a little bit like using a graph. You look across the side and what PPE was my staff member wearing and what were the activities or the exposures that occurred. So was it we were dealing with someone and they were undergoing prolonged exposure? Was it short exposure? Was it transient exposure? And looking through that matrix to work out whether they're a low risk, a moderate risk, or a high risk. Once you've determined for that staff member what was the cumulative exposure risk, we then have to look down the bottom for the low, moderate, and high risk actions, whether they need to be isolated, testing, how long they need to be furloughed for. In the guidance document, if you start to have staffing restrictions and staffing concerns, there's ways of also using this matrix into a staffing matrix to assist you to make sure that you can safely care for your residents. Next slide. Then when we look at the resident or visitor contact, so this is where it becomes a little bit more challenging because residents are in their home and they don't need to wear PPE in their home. So quite often if a resident is positive and they've been interacting with another resident, we're really looking at more of a household-like contact risk section, okay? So if your residents, if you have a resident who's tested positive, and your residents eat all their meals together in a dining room, if it's a smaller environment, or undertake activities in that environment, they hang out with their friends, they spend time together, that's more of a household-like scenario. And we're really looking at, they've had that prolonged close contact, and we're really looking at that high risk scenario there. And that's something that we really need to consider. What is the activities? But if you have a resident who resides in your facility and another resident is tested positive, they may be in the same wing, but potentially another resident doesn't attend the dining room as regularly or chooses not to at all, prefers to have tray delivery in their rooms. What does that risk look like for them? Okay, it also then goes back to looking at whether the visitor was the case and what that exposure looked like for your resident. Do they wear a mask? Did they maintain their mask? Or was the mask removed? Was it inside? Was it outside? So looking at that risk matrix there, some of your residents may choose to wear a surgical mask for their own preference when people visit them as well. You know, that may change the risk matrix again. When we then look at this, again, you move across in terms of PPE and risk scenario, but it's really important that we look in this section when it's resident and resident or visitor and resident, that cumulative exposure, that cumulative risk, and really was it like a household-like contact? Because a lot of the residents who are interacting in their home with their friends, it is likely to be a household light contact, and potentially we're really moving into that high risk scenario. So when you determine whether it's a low risk, a medium risk, or a high risk, we then have a guidance for how is that going to look for your residents moving forward into the exposure and outbreak. Next slide. Yep. Next slide. Yep. So looking at the risk classification, when we look at the low risk, we've determined that there's low risk to your residents, then they don't need to isolate. They're not required to be in their rooms. They're not required to be under any restrictions. We do still recommend that you monitor for symptoms and the usual practices that you would undertake, but they're not required to isolate. Once we get into a moderate risk scenario, we need to consideration for residents to leave their room based on the risk assessment and looking at regular RATs every 7 days for that, every second day for that 7-day period. But what we mean with the consideration for leaving their room based on the risk assessment is that you need to look at the ability to cohort. Can staff be cohorted to prevent the risk of transmission? Can residents be cohorted? Are we able to isolate that section if that's what's most appropriate? Is the resident able to effectively isolate and appreciate what's happening there? If it's a memory support unit or dementia unit, we know that they're not going to be able to remain in their room for extended periods of time and really appreciate what that's going to look like because they don't have the capacity in that regard. So we may need to sort of consider that we may need to extend some sort of cohorted isolation period. Where can they effectively isolate? Are they part of the same exposure or has there been separate exposures? You may have a resident who's been exposed to a visitor and then you may have another resident who's exposed to a different visitor. That will look different. We need to see, can we isolate them in a room while we assess the risk? Can we isolate them separately? Are they in a shared room? What does that look like in that facility? And how is that going to affect their ability to isolate and their ability while you're undertaking that risk assessment? And we don't expect you to undertake a risk assessment in 2 minutes. It's not a case of looking at it going, oh yeah, well that person's this and this person's that. It may be more complex for your facility. So you may need to isolate your residents for a period of time while you undertake testing, undertake risk assessments, really look at the movements of things that happened. So you need to consider what that looks like. But the ones that are high risk, this is more what we're looking at in that household-like contact, that they've had that prolonged period, that they're really living within their facility, within their home and within their community. So they need to isolate for 7 days. And we look at the risk assessment again, look at whether they're going to have a RAT every second day for that final 7 days, and testing every 48 to 72 hours. Okay, so it's really looking, the hardest part of this is looking at what is all the activities that have undertaken, because no two residents' lifestyle is going to be the same. No two staff members are going to be the same. You need to actually break this apart a little bit more and look at everyone. No one expects you to do it quickly, but there's a lot of tools there. So we encourage you to really look at what's their lifestyle like, what's their daily routine like, what's happening. Are they like a household-like contact? Then they're going to be in that high-risk category. And certainly, once you've done your risk assessment, you may then decide to email us and say, hey, look, we've assessed this as moderate risk. Here's some things we thought about. Do you have anything else we should consider? Or we may email you back and say, hey, have you guys thought about, you know, did you have a show on or some community activities? Have you been doing an exercise program together? Is that indoors, outdoors? And give you some other things to consider in that risk assessment. Once you've done your risk assessment, then you need to have a look at who has been exposed and what that looks like. And you need to pop that into a line list. So Gina's going to explain now, what does that line list look like? And how is that a tool that you can utilize to help you, now that you've done your risk assessment, to really see what that impact is going to be on your residents and your facility. Next slide. Thanks, Gina.
Hello everybody, welcome, and thanks to everybody who's presented their bits so far. And I thoroughly agree with Sally in terms of taking the time to do your risk assessment, because if you do a really thorough job of that in the first instance, it will help to prevent any further transmission in your facility and to make sure that you've got the right actions in place. So as Sally was saying, the line list can help you to monitor your outbreak. And another acknowledgement here too, that I know that you've got a huge amount of paperwork to do, and that you may monitor things in your own ways with your own style of line list. We do provide this line list for you and encourage you to use it, but we do understand that it might be difficult and you might already have something else in place. So that's okay, as long as you try and include the details that we really need so that we can help you as well. So the line list it's the who, what, where, when, why and how of what's happening in your facility. It gives us insight that we don't have because we're not physically in your facility, obviously, and as Cara was saying, we do deal with a lot of facilities, so it's hard for us to remember the layout and the number of people and all of those details for lots of facilities. So the line list is part of providing that information for you and for us. And once that information is in a line list, it does help with monitoring the outbreak, but also thinking about what control measures you might need to put in place to further control it if things aren't working, and to just see what's happening in terms of people recovering and so on. Next slide, please, Jenny. So it keeps track of when your outbreak commenced and whereabouts it is in your facility. Is it in every wing? Is it only in one wing? Where is it exactly? It documents how many people in your facility have actually been diagnosed with COVID-19. So staff and residents should both be on that line list. And but it also gives us a picture of the unaffected residents in your facility as well. And the reason that we'd like to know that is because it helps us to work out what we call a strike rate. So if you've only got 50 people in your facility, 50 residents in your facility, and 25 of them end up with COVID, I'm just plucking this out of the air, by the way, that's a 50% strike rate, which is pretty serious. So that's why we need to have all of those numbers. It documents all the symptoms that people are having, or whether they don't have any symptoms, onset dates of their infections, and so it gives us an idea of how long people are sick for, how quickly are they recovering. And that's important information from, not that we're in charge of your clinical perspective on patients, but it does also give you an idea of how patients are travelling with their infections as well. One of the important things, of course, is the dates when people were tested and what the results of those were, and whether it was a RAT or a PCR. So if we don't know when people were tested, when their symptom onset were, it's very hard to try and figure out when we can close that outbreak. And then the other part of the line list is a spot for you to document what your risk assessment was. And that really helps us in terms of knowing what sort of testing should be going on in the facility, what the risk of further transmission might be in the facility. Obviously, if it was a low risk and you're just monitoring for symptoms, that's not going to be as risky as if you'd had some high risk exposures and people, you know, there will be possibly a much higher risk of transmission when you've had high risk exposures. So that's really important as well. And I think next slide, please, Jenny. So that's just a picture of the line list. I know it's very busy and you can't see everything on there really, really well, but I will point out at the end, there's a section there for the risk assessment for you to put in whether it was low, moderate or high. And as Cara was saying, in the future, it's not mandatory for you to report low risk exposures to us. You can if you want to, but that's where you would put low risk exposure, and then you can monitor the symptoms in the section in the middle where it actually says symptom monitoring and what the symptoms actually were. So, but going from left to right, and I'm having trouble seeing this even with my glasses on because it's so tiny. There's a spot for you to write the person's name. Now, I've noticed that sometimes facilities don't want to put the person's name in there, and that's okay, but just to reassure you that this information is all confidential and it's not freely available to anyone in public health. It's stored very carefully, so nobody can access people's names that are on these sheets. But if you feel strongly about not putting their names, just some initials or something like that, the room number that they're in and the wing on the line list is really, really helpful, because if we don't know where they are in the facility, it's very difficult for us to make an assessment of you know, what's happening with transmission, and whether or not we can open, you know, talk to you about opening certain wings after there's been some cases in there, about partially de-isolating people in wings. All those issues are much, much easier for us to help you with if we know the location of your residence. So wing is really important, and if you wanted to, you know, make different sheets for different wings, you can do that, or you can just have it all on the same sheet. So their vaccination status is on there, and all the testing dates, and it'll be a little bit clearer on the next slide, please, Jenny. Thank you. Yeah, so this is a real line list. We've removed the names. It's just so that you can see a little bit of what we mean in how to fill it out. Now, I know it looks a bit, oh my God, what are all these things that we have to fill out? But once you get used to it, it does really make a lot of sense. If you were to use your facility's own line list that you've got set up, that's okay, as long as you can try and give us the information that we need, and preferably in one workbook and not in like 3 separate files if possible, because we are looking at a lot of information from a lot of different places, so that'd be really good if you can manage that. And there's this other little comment section on the far right, and that's another really useful little column, because say, for example, you've had a staff who's tested positive for COVID-19, it would be really useful for us to know whether they were whether they picked up their infection from the community or whether it was acquired at work. And the same with a bit of information about the residents. And as time goes on in our COVID times, and you start to reintroduce activities and things like that again in your facilities, you might find that you've got to be looking at exposures, as Sally mentioned. There might have been some group activities. Is that where the exposure occurred? How many residents were involved in that? When did that happen? You can put all that kind of stuff in that little comments section, and again, it does help us to assess what's been happening in your facility so that we can give you the proper advice. What else? So yes, you can have separate separate tabs for the separate wings if you wish, and you just keep adding to the line list. You don't have to do a new one every time. It's just a cumulative thing that you keep adding to, and sheets for resident cases and a separate sheet for staff. Next slide, please, Jenny. So these are just a couple of graphs that I wanted to show you. It's nothing that you have to do or report, but it's just an illustration of the epidemiological information that we look at to monitor outbreaks, generally speaking. Traditionally, with outbreak management in facilities like aged care or even childcare, the line list usually generates one of these curves so that we can have a look at what's happening in individual facilities. But the epi curves aren't working for us in the line lists as we've got them set up. So we don't expect you to do one, but I just wanted to show you this because the one on the left-hand side is just a summary of what happened on the Central Coast with the Delta outbreak. So the left-hand side of the graph, which is red, yellow and green, was the Delta outbreak back in September and October. And the green, red and amber just gives you an indication of how many of the people on the Central Coast who tested positive for COVID were out and about in the community or not. So the red shows you that they were out and about in the community for 2 days or more. The green says that they were not out and about in the community, and the yellow is a day out in the community. But you can see there that we had the great big Delta peak, and then it eased off round about September and just before Christmas, and then we had the massive surge in cases again with Omicron just before Christmas. So that is Delta. And then the graph on the right-hand side, which is the grey and orange one, is taking you from sort of the end of that section on the other graph through to the 11th of February. This is a little bit different because this shows confirmed cases by PCR and also by RAT, whereas the other graph was all PCR tests. So you can see a similar pattern. We've had a big peak, and it does look like it's starting to come down. You can see that there's been an increase in RAT tests that have been registered. Could be more than that because there may well be RATs that have not been registered, which is a nice segue into reminding aged care facilities that you do need to register the RATs from your residents with Service New South Wales. And I think that is about it from me. Thanks, Jenny, and I think that's my last slide. Thanks, everyone. Am I talking to this one, or do you want to do that, Cara?
Thanks, Gina. Yeah, so we just got some additional resources that we've attached on here that we also send out to you when you fill in your survey on the outbreak survey that you fill out. You get sent these additional resources as well, and then just our contact details again. So yeah, thank you everyone. We really appreciate it. And as you know, Sally and Gina have said too, we're happy to help with anything you need in understanding how to do the risk matrix or understanding how to fill in the line list. We will assist in that. So thank you very much.
Thanks, everyone. We haven't had any questions come through on the question box, but Jack, I believe you have a question you'd like to ask.
Thanks, Jenny. Just for you guys in the PHU, is it helpful for you if when the aged care facility returns the line list or sends the line list through to you, if they send a copy of their floor plan at the same time, indicating exactly which wings the exposure is in? Is that something that you would encourage?
Oh, yes, please. That's a perfect thing to do. It's really super helpful because it gives us so much more insight into the facility, and there is an opportunity to attach that facility plan in the online portal for reporting an outbreak. So you can attach it in there. You can email it to us if you wish, if you haven't used the portal. But yeah, that is one of the most valuable things along with the line list. Super, super helpful. Yes, please. Great question, by the way, Jackie.
I've been around the block once or twice, Gina.
Yeah.
All right. Well,
no other questions. Sorry, Jen. No other questions or comments. Lots of there's been a few compliments to the aged care facility staff from Paul, the director, as well as Lynn. So generally, I think the feeling is that everybody's pulling together and doing a really good job. So well done from that perspective. And that's all from me.
Yes, they certainly are, and we know how hard they're working and trying to take care of their residents and their staff, and it must be really hard. I'm personally glad that I don't have to work in an aged care facility. I think it would be so hard. So yeah, good on everybody.
I may just have one comment to add for the facilities. You know, I've been watching some commentary backwards and forwards on emails over the last, or since Christmas really, where there's this expectation that there will be a case manager appointed from the Commonwealth to their facility when they go into outbreak. And the truth of it all was that that was the intention before Omicron overwhelmed absolutely everybody's resources, but that there was some an email address circulated to request PPE, workforce issues and RAT tests in an outbreak. But that other than in that outbreak situation, all aged care facilities were expected to keep supply up outside of outbreak from their own supply chain. So I did just want to put that out there. There was a lot of angst around not being appointed a case manager, but when they contacted that email address, they were certainly heard and escalated and the PPE or whatever the request was facilitated as quickly as possible. But given the supply chain issues at the time, none of us were immune to it, the Commonwealth, the state or anybody. So I did just want to clarify that whilst I had a few people on the line. So thank you.
Thanks very much, everybody. And thank you very much to the presenters for giving up their time today. There will be a recording of this on our website in our education library. And there's a link will go out to you in the email after this with your certificate in a couple of hours. Don't forget to fill out the evaluation. We really value your feedback, and we'll catch you all next time. Thanks very much, everyone.
Thank you.
Thank you. Bye.
Cheers.
Bye-bye.
Bye-bye.